and give colleagues a chance to join us online. Here's more London people for us. Great.
Oh, it's so warm in here.
Yeah, we just can't see them. And it's Nikos Dedes.
Yes.
Hello, colleagues. My name's Helen Corkin, and I'm a public health specialist who works in London, UK. Welcome to our session on prioritising the quality of life within the context of holistic urban health. We want this session to be as interactive as possible. We've got a 20-minute presentation, but after that, we'd really appreciate, both online and in the room, some questions and some interesting and lively discussion, particularly if you have got some examples of great work or some challenges that you've faced on matching that sort of fourth 90. So without further ado, I'll mention our presenter, Nikos Dedes, who's known to many of you for his great work. Nikos is the founding member and president of Positive Voice, the Association of People Living with HIV in Greece. He is a former president of the EuroAIDS treatment group. He chairs a patient umbrella group, and he's worked on both European AIDS treatment group, treatment trials and guidelines with organisations from the WHO and EDC, to name just a few. Nikos advocates for access to universal healthcare, and that is evidence-based, and that, he believes, is a prerequisite to a prosperous and fair society. So let's welcome Nikos.
Thank you, Helen. Good afternoon to everyone. Today I would be wearing my two hats. One would be the local organization, the People Living with HIV Association, with which I work. And indeed, this is an organization which interacts a lot more with the agenda that the city has and the problems and the groups that we need to serve and what we face. And on the other hand, I'm a co-chair of HIV Outcomes, which is an initiative which tries to make absolutely clear that treating HIV is not about viral suppression, but it goes beyond that, what many times we speak about as the fourth 90, and of course about the quality of life. And this is a kind of work that we do at the European level. And the slides that I have are more for that part of my work, and I hope that for the rest we can have also more lively discussion. So in these slides I will be showing this paradigm shift that for us, people living with HIV, I was diagnosed in 1995. In the beginning, obviously, efficacy and safety were the issues. Now we're talking about convenience, and this is not only the case for countries, Western countries, even in Africa. The issues of tolerability have long been now recognized and are taken care. So I would also be presenting a little bit about the difference of what quality of life encompasses and how is this juxtaposed to health-related quality of life. HIV Outcomes, the initiative that I'm part of, and what is it? And what we have been doing to achieve this recognition at the European, but also at the local level. And of course, after the COVID pandemic, we have new things to face. So, as I already mentioned, we have been living longer, but not necessarily better, and definitely as people age, and we had a session about aging with HIV and all the issues that we face, and we also have to consider that the people affected by HIV are also with syndemics and co-infections, and therefore a lot of comorbidities. Healthcare systems have proven not well equipped to meet holistically the health needs of HIV or any other citizen or patient for that matter. We have been now a lot of us together with academics, with clinicians and patient organizations, we want to go beyond what we call viral suppression, which of course should be the first thing, and indeed access to treatment, which should precede all of what we are discussing today. So quality of life reflects an individual's perception and within the context of a culture, values, and it has to do with how you can achieve your expectations and standards and concerns. But health-related quality of life, we have focused in this initiative at least about the physical, the mental, and the social dimensions. And you can see these two circles where the broader issues, which access to social care and welfare, which is critical for the communities that are affected with HIV, and then of course social isolation, personal relations, of employment status, indeed housing status, are all preconditions and critical for what we... But if we focus on the health-related quality of life, there are some issues which we, within our initiative, have focused more. So, and here you can see that even when one enters into the health-related quality of life, there are a lot of issues about the medical treatment, the pain, the discomfort, the denial of medical care, but the three things that I have pointed here, we are all aware that are the ones that make achieving a good quality of life worse. So, of course, the comorbidities, and as we age as a group of people, but also because of who is more likely affected. People who use drugs are likely to have a co-infection, and also being in the LGBT community means that you may have suffered a trauma, you have been bullied. It's never easy. If you are a refugee or a migrant, again, you are against many odds. And therefore, the discrimination that all the groups face the most are the ones who, of course, increase also our vulnerability. Unfortunately, we see in many countries that there are also some trends not going only towards improvement, but sometimes going back. Unfortunately, even in Europe, this has been the case in some countries. So with the HIV outcomes, what we wanted to focus on was to identify this dimension and make it absolutely clear to politicians within a context where WHO was moving from infectious diseases to non-communicable diseases, rightly so. The morbidity and mortality of non-communicable diseases, again, I mentioned Africa, not that one should expect Africa to have to be otherwise, but these days cardiovascular problems, diabetes are drivers of the morbidity and mortality. Therefore, infectious diseases were not very sexy when we started our initiative. We are back, unfortunately, but we wanted to make sure that this was one dimension that was not missed. And indeed, you can see here how we developed a narrative, we engaged with politicians. We also had a lot of initiatives at the local level. There was one in Spain, quite a thriving one. And of course, then focus and collect data, both within cohorts, but also with other ways to bring out the negative effects that on quality of life, stigma, discrimination, and then of course ignorance might have. So this is what we have been trying, and the fourth 90, actually the three co-chairs, which I should mention from the side of the clinicians, it is Jane Anderson, a clinician who we, people living with HIV, couldn't have a better one, and Jeff Lazarus from the academics. And Jeff Lazarus was together with a couple of people when we wrote about the fourth 90. It was a period when everybody was recognizing this notion of the fourth 90, the fourth 95, whatever the percent ought to be today. And we have seen this at the conferences, but as you can see here, increasingly it has been embedded at the UNAIDS global strategy within the review of double declaration is a declaration that took place within the European region. It included both the EU and the former Soviet Republic countries. It's a declaration which we monitor at the European region to see how well we are doing. And the kind of questions that we ask are decided over time, and their quality of life was included as one of the dimensions. And of course, we want to see this within national strategies. I mentioned already the COVID pandemic, which was a wake-up call. On one hand, I think it demonstrated the importance of health as a precondition for social and economic life. So that has been a positive benefit of COVID in recognizing this, certainly in my country, in Greece. But on the other hand, these four, among other issues, treatment adherence, the double stigma, the psychological problems that were exacerbated with the isolation, social isolation, and what we all have been through, and of course the long COVID itself is another problem. And all of this, if anything, create an extra burden to what we would want to improve in terms of the quality of life. So with that, here you can find us over the internet. There are things that we want to. We have been working also with IAPAC together. Also, of course, quality of life has been one of their priorities, and it has been featuring also in the fast-track cities. So thank you very much, and perhaps on these other issues regarding the things that we have been doing at our city level, we can come back after Helen, you tell us a few things from your experience.
Just to get us to the fourth 90. Oh, great, I'm back on mic. We were wondering if in the audience anybody had some ideas about their experience in their cities. I certainly know that from the work that I've done in terms of qualitative interviewing with people living with HIV, cities, are often at the center of, they're the places where we have excellent healthcare, they're the place where we have the support that let us look at those wider determinants of health that really start to engage and improve lives. But I know that's not the case in every place, and certainly I know that the issues around stigma, whether that be self-stigma or stigma faced in healthcare or the wider community, continue to impact on those quality of life issues. And I'm mindful that you mentioned the first sort of step we have is viral suppression. And I think in my experience, and obviously I imagine in many of your experience, often the things that need to be in place to get viral suppression are those sort of wider needs outside of the sort of biomedical model. It's do I have enough place to eat? Am I safe? Can I talk about my HIV? What's that looking like? And I think certainly the work that we've done in London, we work with our excellent voluntary sector partners, and we've found that projects that actually aim at listening, engaging, and working with the real issues that people face, whether that be the basics that all humans have, a need to connect with people and need to be understood, or the very practical issues such as, if I declare my HIV, will I be criminalized? Can I access treatments? and what that actually looks like really varies for individuals and really massively impacts on their quality of life. We're certainly seeing that there might be a resurgence, you mentioned, in terms of stigma, you know, whether we're facing that mental health crisis potentially moving forward post-COVID. So without me continuing to talk, I wanted to check, do we have any questions in the audience?
And as we wait, I wanted to give one example. As you know, of course, Greece went through a very famous crisis in the last decade. And what that meant was that we also experienced one of the fastest growing and largest outbreaks there has ever been in people who use drugs, an HIV epidemic. HIV was very low in people who use drugs in Greece, and it skyrocketed. And then, of course, all of that was the absence of clean syringes and equipment. So if one does not deal with a holistic manner for very cheap interventions, which are very effective, immediately everything collapses. The other thing is that you really need to have sensitive and well-designed harm reduction programs at the level of the city. Yeah. HIV is an urban disease, and the most affected communities are also in the metropolises and in the cities. And the other thing that Greece has experienced is the refugee crisis and the influx. We had large numbers, and for many years we had very low percent of people who were non-Greeks with HIV. It was 20%, which is very close to what is the also composition of migrants in Greece. But in other countries in Europe, let's say in Sweden, you have more than 90% of all new diagnoses in people who are not of Swedish origin. This immediately demonstrates where the problem lies. And in many cases, it's not because people were infected and went to Sweden. It is because the vulnerability continues with your being a migrant. So we have seen now in Greece a doubling of diagnoses on people from third countries. So once again, unless, and then of course one of the problems that we face as an organization is linking people to health. And if there is a problem in achieving linkage, you either do not treat the person who is diagnosed or you do not diagnose. So I gave just two examples with what we have experienced with people who use drugs and with refugees, which is outside of the health system in order to have a successful response.
Yeah, I think that's illustrated beautifully, that unless we meet the needs of everybody, we're not going to get to any of our targets in terms of HIV. Did we have any questions from the audience in the room? Thank you.
Yeah.
Sorry, could we give you the mic? Yeah, sure.
So my colleague Lauren and I work for a charity in Manchester called George House Trust, and our remit is that we work, our referrals come from clinic, they're the most complex patients, so they're not only have poorly controlled HIV, they have comorbidities, poor mental health, they might have drug and alcohol problems, housing problems, financial problems, and our remit is that we get them down to undetectable, and then we're supposed to close their cases. Wow. But what happens is we find that some people are very difficult to close because they just wouldn't manage without us. It sounds like we're disempowering people, but these people are really very, very vulnerable, and it's getting funders to realise that it's much more than getting people to undetectable. You know, some people need help for a lot longer, we found, don't we? We found. But, I mean, there are some quick fixes. There is some good news. Like, one of my clients at the moment is an Ethiopian refugee, and she'd always been really treatment compliant, and then the property that she lived in, social housing, was condemned for health and safety reasons, and she ended up in the most awful bed and breakfast. Awful, because that's all housing could find to put her in, with people with drug and alcohol problems. And this is a middle-aged Ethiopian lady, very religious. And for the first time, for absolutely years, she stopped taking medication, ended up with encephalitis, with a fairly lengthy hospital admission. And I worked with the homelessness team in the hospital, and on discharge, at the very last minute, they managed to get her into some supported housing, and the difference is phenomenal in her. She had her first hospital appointment yesterday since discharge. I'm fully expecting her viral load to be undetectable again. And she has such a big smile every time I go around and see her, because I've been sort of supervising a medication, but I'm not allowed to escape from the flat now without tea and coffee and big plate of biscuits, because the difference is phenomenal. And this is someone that was in hospital absolutely terrified of going back to that horrible dirty hotel, and she was tearing at her face. She was really distressed. But I do think that now she's going to get help with housing. But if something went wrong in the future, and she ended up in that situation again, she would be right back to square one. And we do see housing is the bane of our lives, isn't it, Lauren? We work in a really deprived area, and housing is a real problem.
Thank you for sharing that. I think it perfectly illustrates with that sort of one case how quickly things can fall apart when somebody's actually been thriving, and how important it is to make sure that actually, whether it be our funders or our policymakers or our politicians, understand that actually there's a wider context and people live their lives. Thank you.
I thought there was someone else who wanted to...
Yeah, next question.
And I would like to add in your response that I think that here is a clear space for the work of the cities and municipalities. The services of the state, certainly in my country, in Greece, the experience might be completely different. They work in silos. And what is definitely when you do case management, what you need is to make sure that you have the appropriate referrals, the appropriate coordination, the appropriate, and there, my organization, which is a small organization, doesn't have the resources even to have the full picture or to ask a question and get an answer. And therefore, that is where we believe that, an initiative from the city, even for street work activities, where everybody has something and nobody coordinates, nobody knows who is doing what, who offers what, where there is food, where there is something to put on. So I think the cities can play a huge role. I mean, the state could play a role, but perhaps it would be much more difficult machinery to do that.
So I just wanted to add some of the challenges we face. I'm in the U.S., in Texas, which, as you know, has a terrible healthcare system. We do actually have resources for people with no income. And so at our organization, we provide dental care, meals, housing, case management, mental health, and a clinic, and pharmaceuticals, all the wraparound. And so if you have no income whatsoever, we can help you. The idea is to get folks into more permanent housing, and that's signing up for social services and getting to that point. The bigger issue comes with the people that are a step above. So they might have insurance, but it doesn't cover enough. Or in the U.S., you can be on your parents' insurance until you're 26. So that's our problem right now. We have our numbers in people under 24 are increasing pretty significantly, and those folks come to us because we can do the free testing and all, but to treat them and to provide the medication, we have to go through their insurance, but they don't want us on their insurance because then their parents will know about it, and they may not be even out to their parents, and they certainly don't want to tell them that they have HIV yet, or they're not ready for that. So we have to find other avenues. The non-insured program that we have, they're not eligible for. Because if we sign them up, it becomes a problem and it becomes a legal issue. We have some ways around it. We can usually get them through a few months with samples and whatnot. But that's one of the challenges, is they have a little bit too much, and we don't have resources to support those folks. So that's one of the challenges. If they have no insurance, they're okay. We can take care of them. If they have insurance, it becomes problematic. And then we have another level, which really just came to my attention last week. So we've been around since 1986, like a lot of AIDS service organizations. The early folks who were there at the time, who are long-term survivors, they're now in their 50s and 60s, and they're financially secure, but they still need support. And organizations like ours have become so focused on indigent care that we're not offering the support, and there's not a support network for that population. And we had a reunion last week, which is how it came up. And all the talks today have been really interesting, because I'm starting to think, how can we bring those folks in to provide that community support that they need. They don't need the financial support so much, but the community support to continue for the next 40 years of their life.
Thank you. I think that's an important one, and it's certainly come up in the work that I've done. It's often not, it is the most at risk, but it's also the ones that are just below that threshold where we actually need to start to target those things. And I think you highlight really well the fact that actually when you're meeting diverse communities, they have diverse needs, and to sort of manage those concurrently in resource-tight environments and in politically challenging environments is always going to be a struggle. It'd be really interesting to hear other people who've experienced that and some of the projects that have worked on that. But Nikos, did you have any comments for our colleague?
I was wondering, how big is your organization?
Well, so there's three main AIDS service organizations in our city. We're a city of a couple of million. My organization, technically we serve over 3,000, but a lot of those are just people on our roster for meals or for oral health care, because we're the only ones that provide oral health care.
I'm asking because you had a huge diversity a lot of diverse services, which you developed vertically.
We have 62 staff, and we probably have about 900 people that we serve in all of the programs on a regular basis. The extra couple thousand are sort of one service we provide.
And may I ask, how much has been the mental health burden for your beneficiaries, and how much do you have healthcare, trained for that?
So our mental health providers, we have 2 licensed professional counselors only. We're trying to get a psychiatrist on contract, which is not funded. We're trying to find some other funding for that. There are other providers, but that's a limit. There's right now in our city of 2 million, there's 1 psychiatrist that will work with our patients with HIV. Obviously, they're 3 or 4 months out. So our counselors do pretty well. I'm getting another psychiatrist that is going to contract with us, but again, we have to find separate funding for that, so that's a huge burden. Our clinic is actually fairly small, and that was, we transitioned from hospice nursing home care to outpatient care 5 years ago, which was actually before my time there, and it had very, very limited clinical services. That's my goal in coming, was to change that and expand that pretty dramatically, but that takes a lot of resources. So our supportive services are pretty substantial, but both the mental health care and the clinical care is still on the smaller side.
Thank you. That's it, communal sharing.
Yeah.
Thank you. Thanks very much, Nikos. And I should, full disclosure, I've known you for a long time. And one of the things I appreciate most about you is the ability of Positive Voices to respond to really dramatic, intense changes that have happened in Athens. And it's really, it's remarkable, and I know that that's under difficult situations. You talked about a paradigm shift, and I know what that means. It's about re-looking at a situation from a dramatically different or radical way, as opposed to the sort of common way people think about things. in my situation, just for an example, I used to think of myself as a person who was HIV positive who had other problems. And now I think of myself as a person who has mental issues, neurodiversity issues, and who, because of that, was much more likely to become HIV positive and much more likely to continue to have ongoing health problems. And I think it's what you're talking about is the idea of having a paradigm shift to really look at things differently. I think it really needs to be explored from various points of view. Knowing, I mean, we've talked about the case of, you know, a person who has a mother with kids and HIV is not her main issue. And I think it's really important as an exercise to begin to think that quite huge numbers of people who are either available to become HIV positive or are already HIV positive have other key issues that are going to impact, as you gave the example of something's going to happen to them and their life may change dramatically. And it may have nothing to do with their HIV at all, but it impacts their HIV. And I don't know how to unpack this discussion about paradigm shift, but I think it's really, really important. I think Fast Track Cities is really a good model of looking at the city from looking at HIV from the city point of view rather than the way we used to look at it. And that's a paradigm shift that I think is very important. And I think that what I've seen in London in Fast Track Cities is the idea of really focusing on marginalized populations specifically, and then working back about centering those people so that they're available for many of the services that a more established, older HIV positive person like me has taken for granted for years. So I don't know how, would you like to say more about that shift notion?
First of all, you may recall, for us who were diagnosed, and for you for many, many years before me, you know, the target of treatment, according to the guidelines, was to achieve undetectability. That was a target. And once you achieved that, you know, the body took care of the rest. And that was then used from UNAIDS as the programmatic target, because the 390s, each one actually is an indicator, a quality indicator of what you have done correctly in order to diagnose people and test and offer those services. If people are linked and are put on treatment, it's a good indicator that the health system is responsive, it's universal coverage, and irrespective of insurance. If you get the people who diagnose on treatment, that is the indicator. And then the final indicator is, I mean, how many are undetectable? It means, are the drugs good because people can stay on them, or is the service that the clinicians are offering, do they provide you know, guidance on adherence? Whatever it is, that is what it shows. And obviously nowadays it's not enough. We used it first for treatment and then for the programs. The UNAIDS said that's it. If you achieve that, it means everything is working. And now, from what you are describing, and by the way, the 490, the way that we perceived it, of course, all of us, it is not just about people living with HIV, but whatever it is that is a requirement, it is for all those communities affected and at risk to HIV, who, if you have this paradigm shift, and it is interesting what you just said, even though we have discussed it before, it's almost a revelation, always a revelation, that actually it was other issues that make you end up a person with HIV. And today in the LGBT community, chemsex is something that is so much linked.
It can be,
with the end result of, and then of course, why do people do that? Again, it's an issue of quality of life, quality of relations, quality of sex life, which somehow is not sufficient, and people resort to, what's the word, to using drugs.
Enhancement.
even for, an activity which didn't need a lot of enhancement in my time. So yes, it's, I think we have to see it as for what it is, and then try to find solutions.
Yeah, I mean, I think you make again the point, fine, we're coming back almost full circle to that sort of Maslow's hierarchy of needs, and as much as we talk about a paradigm shift, I don't think we can ignore that there's a very real threat as we move to right-wing populism, that quite a lot of the progress we've made is at risk for the communities that are most marginalized, whether they be migrants facing xenophobia and racism, LGBT communities, poverty, as we're facing economic crisis in the global sphere. And we don't exist in a vacuum, don't we? These impact on our lives. We internalize quite a lot of those messages, and it makes each and every one of us vulnerable to a certain extent. I liked what you said about how we address those needs. I work in London. I'm fortunate enough to work with great colleagues in that city, and we try to move away from that sort of biomedical model. So some of you may have heard of some of the great work that we do with opt-out testing in emergency departments. My colleague Ian, one of the key components of that he was keen to embed in that program was that some of that funding goes for peer support. It goes for the wraparound holistic care, the kind of things that addresses those needs. Can you get recourse to public funds? Can we look at your housing? Can we look at your mental health needs? Can we look at how connected you are? What's loneliness look like? And it's actually only by embedding that do you keep people in care, do you improve their lives, and we see people thrive, not just exist, not just live for longer, but able to tackle those many issues that are just essentially humankind issues, aren't they? Did we have any more comments or questions from the audience? I know we've got the graveyard shift a little, so thank you all for staying with us. Okay, what I would like us all to do is really thank Nikos for his work and his commitment.
And thanks to Helen and the agency and the great work that you do.
Thank you. We love working with London. And a huge thank you to IAPAC for hosting this session, and I wish you all a great conference. Thank you.